Good morning, guys. We are Group 6, and we will be presenting on narcotics, otherwise known as opioids. The group members are Shanake Manning, Kino Irving, Dominique Francis, and Karifa Warner. So here we have some objectives of this presentation. So at the end of this presentation, students will be able to define narcotics, list common types of the drug, explain the effects of the drug on the CNS, appreciate the relation between the class of drug and oral manifestation. Finally, identify the implications for dental treatment. So here we have a quote by Carl Jung, which reads, "Every form of addiction is bad, no matter whether the narcotic be alcohol or morphine or idealism. Despair is a narcotic. It lulls the mind into indifference." So even though a good quote, I think it can be misleading where it is classifying alcohol as being a narcotic when alcohol is really a depressant. So firstly, what are narcotics? So in this objective, we will be giving a definition for this topic, as well as background information on the class of drug. So opioids are made from alkaloids, which are naturally occurring plant compounds found in the opium poppy plant. Furthermore, other opioid drugs are synthetic, meaning they were created in the labs by humans. An opioid drug, on the other hand, may contain both naturally derived and synthetic ingredients, as well as other drugs. So here, if you look to the left of the screen, you'll be seeing a picture of the poppy plant. So we'll be looking at narcotic addiction on this slide. A person using opioids over time can develop tolerance, physical dependence, and opioid use disorder, with the risk of overdose and death. So when a person uses opioids up to a point where it becomes an addiction, the diagnosis, or what we refer to that as, is considered opioid use disorder. So all opioids function in the same way, whereas they stimulate opioid receptors, which are a group of nerve cells found in the brain and the body that basically blocks the transmission of pain signals from the brain to the body, which basically gives a euphoric feeling, hence why you don't really feel pain when you're on these drugs. So opioids include substances like morphine, heroin, codeine, oxycodone, hydrocodone, and fentanyl, among others. Your patient can present with these signs/symptoms, and they are as follows: drowsiness, constipation, euphoria, nausea, vomiting, and decreased breathing. So here we have a few did you know. Firstly, opiates are made from the naturally occurring poppy plant, Papaver somniferum, which yields the drug's active component. Codeine, morphine, heroin, and opium are examples of common opiates. Secondly, an opioid is a drug whose active ingredients are made chemically in a lab, synthetic or semi-synthetic, meaning it can be obtained from the plant. All opiates are opioids, but not all opioids are opiates. However, opioids and opiates have the same effects on the body because they have similar molecules and they both have high addiction potential. Now we'll be moving on to the second objectives, where we'll be discussing the types of opioids and we're going to list the common types. We have morphine, oxycodone, hydrocodone, fentanyl, and methadone. So this slide basically depicts the images of the drugs, as well as we have added the street names of the drugs. So first we have morphine, and it is referred to as Miss Emma or Roxanol. So if you have a patient and you hear a patient say, "Doc, 1 and 2 times we take a Miss Emma," you know that he's referring to morphine. Oxycodone, it's referred to as OC, Oxy or Oxycontin. Hydrocodone, Fluff, Vic or Hydros. Fentanyl, Apache or Dance Fever. Finally, methadone, chocolate chip cookies, Mariah or Fizzies. Now I'll be handing over to Kino, who will walk us through the effects of opioids on the CNS.
Thank you, Jean-Michel. Opioids have an effect on the central nervous system thanks to opioid receptors in the neuronal cell membranes. The effect of opioids is dependent on where in the central nervous system the receptors are located. In the spinal cord, opioids' analgesic effect occurs when a pain signal reaches the synapse from the periphery. Opioid receptors are G protein coupled to potassium ion channels and voltage-sensitive calcium channels. When opioids bind to receptors on axon terminal, they close calcium channels to reduce calcium ion entry into the primary neuron membrane and open potassium channels and increase outflow of potassium ions from the secondary neuron membrane. This causes a decrease in neurotransmitters such as substance P and glutamine from the axon terminal of the primary neuron. Decrease in neurotransmitter release from the primary neuron leads to less excitation, hyperpolarization, and decrease of the duration of action potential in the secondary brain, and decreases the pain signals sent to the brain. In the brain, opioids' euphoric effect occurs when it binds the GABA inhibitor neurons. Dopamine is responsible for the pleasurable feeling individuals get when doing something they enjoy. Usually, another neurotransmitter, GABA, binds to receptors on the membrane of the neuron, releasing dopamine. This inhibits the release of the dopamine. However, when opioids are introduced, they bind to receptors on GABA inhibitory neurons, thus reducing GABA activity, increasing dopamine release, and causing pleasurable feelings. Due to the euphoric effect opioids produce, there is a high risk of addiction associated with their use. I will now hand over to Karifa to discuss some of these.
Thank you, Kino. Now we're going to be talking about narcotics and how the abuse of this drug is manifested in the oral cavity. So, what are some oral manifestations that indicate narcotic abuse? So, major oral health issues such as generalized dental caries, generalized tooth decay, in particular on the smooth and cervical surfaces, periodontal disease, mucosal dysplasia, xerostomia, tooth wear, and tooth loss are all linked to narcotic drug abuse. Some of the more common manifestations are xerostomia, which is dry mouth, tooth decay, and tooth loss. Now, as mentioned earlier by my colleague Shauna Kay, morphine is a type of narcotic drug. It causes mineral loss and nutritional deficiencies in the tooth, both of which can have a negative impact on its structure and making the tooth susceptible to caries. An oral manifestation of morphine abuse is xerostomia. Now, if we look to the right, we can see two images. Now, if we look to our right, we see two images. We see the healthy tongue versus someone who has xerostomia. We know because the tongue appears shriveled and dried up. The next drug that we're going to be talking about is methamphetamine. Now, this is a highly acidic drug and it destroys the tooth structure very rapidly. Methamphetamine also tends to dry out the mouth, xerostoma, resulting in less saliva to wash away the acid, keeping the teeth clean. Now, looking on this diagram, we can see some discoloration in the teeth. We can also see some fractures if we look at the lower lateral and central incisors, tooth number 25 and 26. We can see some small fractures along the midline, not sure if you can see it. Also, the right mandibular canine, there's another small fracture towards the mesial portion of the tooth. We can also see some severe cases of tooth decay on multiple teeth in multiple arches. And of course, there is tooth loss. If we also take a look at the maxillary right canine, we see that the tooth appears flattened. This can be an indication of bruxism from maybe teeth grinding or clenching. Okay, so moving on, we're going to be looking at heroin, which is another narcotic drug. Persons who use heroin usually display poor oral health in terms of caries and periodontal disease. Now, according to a study that I read on, patients have progressive dental caries regardless of their oral hygiene, whether it be good or bad. And caries is normally darker in patients who overuse or abuse heroin. These caries are usually limited to the buccal and labial surfaces. So next, we're going to be talking about methadone and hydrocodone. Now, like morphine, these two drugs are acidic and can attack tooth enamel. Both drugs reduce saliva, causing xerostomia, as we said, dry mouth, and the saliva protects the mouth and helps to reduce tooth decay. Now, some other adverse effects of opioids abuse. Most persons who use opioids or opiates develop a bad habit of grinding or clenching their teeth, which may cause it to crack, especially in older people. And we know that grinding or clenching can result in bruxism. Next, being high on these drugs could also make it more difficult for someone to remember to brush their teeth and floss on a regular basis. Now, a decline in good oral health hygiene practices can make one susceptible to dental caries and other viral infections affecting the mouth. Finally, some narcotic drugs, such as heroin, increases cravings for sweet foods, and we know that the combination of sugar and bacteria in the mouth can lead to the formation of plaque, which, if not properly treated, can lead to cavities. I'll now hand over to Dominic, who will be talking about the implications for dental treatment.
Our final objective was to identify the implications for dental treatment. Our first implication is patient's behavior. Significant alterations in social behavior are frequently linked to opioid dependence. Regardless of their financial situation, opioid addicts usually exhibit a neglect for personal or dental hygiene. As a result, opioid users frequently defer treatment until the condition has progressed and the symptoms are severe, which may explain why dental caries are so common among these addicts. Users of opioids frequently experience psychological issues, which are frequently accompanied by general worry. Any typical worry linked to a psychological disease may be greatly amplified when under the impact of severe pain. This could account for the increased dental fear and anxiety that is frequently displayed by opioid addicts. Some of the signs in their behavior include mood swings, physical agitation, slow breathing rate, low blood pressure, anxiety attacks and episodes at any time. These are also very scary situations for dentists, as these patients are very unpredictable. And so for both the patient and the dentist's safety, it is suggested that these patients be placed on an opioid agonist to help reduce the effects of these opioids, and the treatment should be postponed until the patient is fully recovered. Treatment doesn't only mean cleaning the teeth or eliminating the dental issues, but also educating and managing the patients. However, sometimes it can be very difficult to reach out to these patients. We'll also need to remember that opioids are analgesics, so therefore any pain arising from dental lesions may be masked or ignored due to the analgesic or mental detachment effects of opioids. Some side effects of opioid drugs include nausea, vomiting, and constipation, together with the risk of hypertension and respiratory depression. These can lead to seizures, shortness of breath, and unconsciousness, and therefore the dentist has to be extremely cautious when seeing these patients. And again, the treatment should be postponed if these signs are presented. Our next implication is medical problems. Opioid drug users are more likely to experience a variety of medical issues with multifactorial causes. Opioid users are extremely prone to catching various illnesses. These typical infections have consequences in a dental context and include HIV, viral hepatitis, and infected endocarditis. In light of this, it may be necessary to evaluate these patients before performing oral surgery and other dental treatments that could result in a serious bloodstream infection. The dentist must be also aware that patients who are drug addicts may have infections that have special consequences for dental care when treating them. Standard measures must be taken when treating opioid addicts due to the high incidence of these infectious diseases in the group of patients, even though a full medical history may not disclose the presence of such illnesses or infections. Our final implication is administering local anesthetic. It is commonly acknowledged that post-operative pain management in patients who are opioid tolerant can be particularly challenging. Opioid users may demonstrate a reduced responsiveness to local anesthetic due to the properties of the opioid, as well as general fear and anxiety. Research highlights that this may also represent a decline in the strength of the local anesthetic. These patients' therapy options are further constrained by this decline, which also raises the danger of major local anesthesia-related adverse effects, such as local and systemic toxicity. As a result, an opioid-induced reduction of local anesthetic strength may present a serious clinical issue, especially considering an increase in the use of opioids as a primary method of managing perioperative pain. Therefore, it should not be sufficient to simply cut patients off opioids prior to surgery due to the ongoing decrease in local anesthetic potency. But putting these patients on an opioid agonist or using different forms of sedation could be more effective. Along with all that was mentioned, gaining the patient's trust through a compassionate and empathic approach will frequently result in more effective pain management, more reliable attendance, and an overall effective treatment. And this concludes our presentation. Thank you for listening, and I hope you guys learned something.